Good afternoon, everybody, and thank you for joining our webinar on Lynch syndrome and colon cancer. I have the pleasure to be joined by a very amazing faculty who will give you a brief overview on the key points on this mutation. But first, I'd like to have everyone introduce themselves, starting with Sarah Ertan.
Of course, I'm Sarah Ertan, and I'm one of the genetic counselors in our Lynch syndrome clinic.
Okay, Dr. Singh.
Thank you, Dr. Munster, for the invitation. My name is Singh. I'm a gastroenterologist here at UCSF, and I'm also the director of GI Cancer Prevention Program and Lynch Syndrome Center. I am very excited to join today.
Thank you, Dr. Terdiman.
Good evening, everyone. I'm Jonathan Terdiman. I'm the chief of the gastroenterology division at UCSF Health, and I've been taking care of patients and families with hereditary GI cancer syndromes through my entire career of 30 years.
Okay. Amie Blanco.
Thank you, Dr. Munster. Hello, everybody. I'm Amie Blanco. I'm also a genetic counselor. I'm the director of our Cancer Genetics and Prevention Hereditary Cancer Programs. And like Dr. Terdiman, I have spent almost my entire clinical career taking care of patients that are at increased risk for colorectal cancer. So it's a pleasure to be here.
Thank you all. And before I hand it over to Sarah, giving us a brief overview, a few words on our program. The hereditary program is really geared towards individuals with mutations that puts them at risk for cancer. We also want to really be a resource for family members of those who are affected with a mutation and those family members who may have a mutation that do not know yet. This webinar series is sponsored by a very generous donor of ours, and it's posted on our BRCA website. And I think Dr. Taniwaki will put the link of the BRCA website into the chat. As we go through these brief discussions, after that will be followed by a panel discussion. Please feel free to put questions in the chat. We'll answer this and we'll go from there. Sarah, you ready to start?
Of course. Give me just a second to share my slides with everyone. Perfect. So to go ahead and get us started, today I'll be sharing a little bit more information about colorectal cancer, including how it develops and different risk factors. I'll be talking specifically about hereditary colorectal cancer conditions, and I'll briefly discuss some screening considerations as well, although you'll also hear more about that from my colleagues later on today. So to start, colon and rectal cancers are often grouped together because they're very similar cancers. They just start in slightly different places, either in the colon or rectal. So you'll be hearing me to refer to either colon cancer, rectal cancer, colorectal cancer throughout the presentation, but I'm referring to the same thing. And these cancers are one of the most common cancers worldwide. The average lifetime risk to develop a colorectal cancer is about 4%. And you can see a quick visualization of that in this little graph here. So anyone can develop a colorectal cancer. So let's get a little bit more into some of the risk factors. So age, unfortunately, just getting older can be a risk for colorectal cancer. And we know that most of these cancers do happen later in life. Other risk factors like being overweight or obese can increase your risk, while we know studies have found being at a healthy weight can actually help lower your risk for colorectal cancers. There's also different actions we can take to increase or decrease our risk. So we know that diet can play a role. So eating a lot of red meat increases the risk versus diet higher in fruits and vegetables decrease the risk. Also things like smoking or excessive alcohol use can increase the risk for colorectal cancers, as well as other cancers. There's also risk factors that we have less control over. So we know that people who have had colon cancer or who have certain types of colon polyps might be at a higher risk for colorectal cancers. We also know you can't control your family history, but having a family history of relatives with colorectal cancer or with a genetic condition such as Lynch syndrome or FAP can also increase your risk. And then just to really quickly review, genes are the instruction manuals we're born with, something that helps our bodies grow, develop, and function. We get our genes from our parents, we pass them down to our kids, and I'll talk more about that later on as well. So genetics, environment, behaviors, all of these different things can play a part in colorectal cancer risk, but you might be wondering how big of a role do these factors play and how many cancers are related to genetics. So here's just a really quick graph. So we do think that most colorectal cancers happen due to bad luck, random chance, or other factors we don't always understand. But a small percentage of cancers are due to genetic risk factors. And it can be really important to know if a cancer is genetic, related to genetics or related to something else, because it could impact treatment or management. It also tells us a little bit more about risk for the family. So a small percentage, but an important percentage. And cancer genetic testing really tells us a little bit more information about your lifetime risk to develop cancer. For people who haven't had cancer, knowing your genetic risk might help with screening, hopefully to prevent a cancer or to catch a cancer when it's easier to treat. And for people who've had colorectal cancer, results of genetic testing might help you make decisions about your treatment and understand if there's risk for other cancers or risk for family members. So really quickly here, there are many, many genes that can increase the risk for colorectal, and we're still discovering more. One thing that I want to point out, 2 genes you don't see on this list are BRCA1 and 2. BRCA1 and 2 increase the risk for breast, ovarian, and prostate cancer. And there's been a little bit of a question on whether or not they could also increase the risk for colorectal cancer. There have been 5 large case studies looking into this question, and currently we don't recommend any increased colorectal cancer screening for people who have BRCA1 or 2 gene mutations. But for other genes that are listed on this slide, there are certainly recommendations because we do know that these genes increase the risk. So just very quickly going into the background of how colon cancers develop, most of the time colon cancers start off from colon polyps. And it's not unusual to have a colon polyp or 2. Not all colon polyps go on to become cancer, but it is part of the reason we recommend routine colonoscopy screening starting at age 45 for everyone. And it is something that I'll talk a little bit more about how some of these genetic conditions might increase that risk for cancer based on polyps that do develop. So going back to that list I showed you just a second ago, we often lump colorectal cancer genetic syndromes into 2 big groups based on what types of colon polyps or how many colon polyps develop. So polyposis means that someone develops a lot of colon polyps. And I'm talking like 50+ colon polyps over the course of your life, and sometimes hundreds to thousands of colon polyps. So not 1 or 2, but a lot. And that can increase the risk for colorectal cancer just because there's so many polyps that are developing. Versus other non-polyposis genetic syndromes, people still might develop colon polyps. And it's more that those colon polyps are more likely to become cancerous or turn into cancers quickly. Kind of 2 different ways that these genetic syndromes work, but increased risks for all of them. Really quickly, I'm not going to stay on this slide for too long, but it is important to know that genes have different risks. So for a condition like FAP here at the top, there's a very high risk for colon cancer if people don't have treatment, versus for a gene like CHEK2 at the bottom, there's still an increased risk, but it's not quite as high. So it's important to understand those risks and to know what they are for you if you do have a genetic syndrome. And to briefly review one of the most common colorectal cancer genetic syndromes, Lynch syndrome is the condition, which is caused by harmful changes or mutations in one of the 5 Lynch syndrome genes. So you can see them listed up here: MLH1, MSH2, MSH6, PMS2, or EpCAM. The cancer risks are slightly different depending on which gene isn't working, but overall people with Lynch syndrome have an increased risk for colorectal cancers, endometrial cancers, and some of the other cancers listed here. And often these cancers happen at earlier age. So because of this, we do actually have different screening recommendations for people with Lynch syndrome. So I won't go into these details too much, but we do, for Lynch syndrome patients, things like earlier and more frequent colonoscopy screening. So we don't wait until someone with Lynch syndrome is 45. We would start colonoscopy screening in the 20s or 30s and repeat it more often. Similarly, there's additional screening for people with Lynch syndrome due to the other cancer risks. So if you have Lynch syndrome, it's important that you follow with your care team for specific screening recommendations. These are just general recommendations, so make sure you're working with your team to get the right screening. Lastly, you might be wondering, is this something that I should be worrying about? Would genetic testing be right for me? So genetic counselors' role is to help people understand their risks and make decisions about testing and screening that are right for them based on their personal and family history. So you might want to consider meeting with a genetic counselor if you have a personal history of colon cancer, if you have a close relative like a mom, sibling, child with colorectal cancer, if there's multiple people in the family with cancers, like endometrial cancer in your mom and colon cancer in your uncle and your grandma, that might be a reason to meet with a genetic counselor. And you can always meet with a genetic counselor or genetics professional if you just want to know more about your colorectal cancer risks and whether or not screening or management might be best for you. So to wrap things up, anyone can have colorectal cancer. It's important to understand your risks and get screened for colorectal cancer. And also genetic testing can provide important information about cancer risks for you and for your family. So thanks for listening to my part of the presentation. Feel free to add any questions that you have into the chat, and I'll turn it over to my colleagues to tell you a little bit more. Thank you.
Thank you, Sarah. Much appreciated. Dr. Singh, over to you.
Perfect. Well, thank you, Sarah, for a nice overview. Let me share my slides. Can you see my slides okay?
Yep.
All right, I hope I'm in presenter. So in next couple minutes, 10 minutes or so, I'll be talking to you about some clinical management of hereditary colorectal cancers that Sarah alluded to. I have no financial disclosures. So just going back, cancers, so if you have multiple cancers in your family, it can be labeled as familial cancer versus hereditary. So familial cancers the definition is used if you have multiple family members with colorectal cancers. And when I say family members here, we are talking about blood relatives. So you do have multiple family members with cancers, but there is no gene that's identified in the family. Those are familial cancer families. On the other side, there is hereditary cancer, where there is a gene that's known in the family and that explains the cancers. So now coming to hereditary colorectal cancer syndromes. So there are polyposis syndromes and some are non-polyposis syndromes. We talked a little bit about them. And in the polyposis syndromes, there are multiple that include FAP, which is familial adenomatous polyposis syndrome. Second one is MAP, which is MUTYH associated polyposis. And the third one is hematoma polyposis syndrome. Here you can see that some of these are extremely rare. And now if you go to the other type of colon cancer syndrome, which these patients do not make a ton of polyps, and the most common one is Lynch syndrome. Here, I would like to take a pause for a moment for you to think that how common is Lynch syndrome? It's extremely common. It's much more common than we think. 1 in about 300 to 350 individuals in the general population are assumed to have Lynch syndrome. But the sad part is most of these individuals, 90 to 95%, are thought to be undiagnosed, meaning they carry the gene, but they haven't had the testing yet. So again, not going into too much clinical jargon here, just to show you that different polyposis syndromes, they all have different gene mutation associated with them. So these syndromes should, even though they are all causing multiple polyps, they should not be used interchangeably. So the gene is different, and the risk of colorectal cancer associated with these syndromes is also different. Here you can see the most important one is FAP, where the risk of colorectal cancer can be as high as 100%. So these individuals are almost guaranteed to develop a colon cancer in their lifetime. Therefore, their management involves not just a colonoscopy, even a surgical removal of the colon before they develop colorectal cancer. So let's talk about which screening methodology is preferred. So now there is a family history of colon cancer, you had genetic testing, and what screening options exist for you to get tested for your risk of colorectal cancer. So the right answer for these is high quality colonoscopy. And that is preferred in high risk individuals. And high risk is defined as anyone who has family history of colon cancer and or if they have a known genetic mutation as well. And the other screening options, what about them? So the other screening options for colorectal cancer screening are annual stool-based FIT testing. The other one is stool Cologuard, or every 5-year CT colonography. In high-risk individuals, we do not recommend these testing options. And I must add, as of now, multiple clinical trials are going on. There is one FIT test trial for Lynch individuals is going on in Europe. There is a Cologuard going on here at 2 institutions to see if some of these Lynch syndrome individuals can undergo some stool testing and if that can be used instead of colonoscopy. But the right answer as of now is for high-risk individuals, the recommended method of colon cancer screening surveillance is a high-quality colonoscopy. And what about blood tests for colorectal cancer screening? The short answer is not ready for prime time yet. Lots of exciting and promising data coming up for blood tests for septin-9 and cell-free DNA for colon cancer screening and multiple like other organs cancer screening as well. Like can we use that in clinical practice as of now? I would love to do that, but I would like to see some more data before those are included in any of our guidelines. They are not there yet. So when to start screening for colorectal cancer? So we all know that if you are an average risk individual, we should be starting at age 45. And for average risk, meaning you do not have a known gene mutation or a family history, then you should start at age 45 and repeat every 10 years. And for these average risk individuals, it's fine to use a stool-based testing like a FIT test or Cologuard if that's your interest. However, in individuals who have family history of colorectal cancer, as we said, we recommend colonoscopy, and that should be starting at age 40 or 10 years before the age of diagnosis. And it should be repeated at least every 5 years. So what that means is if your dad had a colon cancer at age, let's say 45, so you should be starting 10 years before the age of their diagnosis. So that will actually mean at age 35 for you, and you should repeat every 5 years. Here is a slide just to show you the importance of good bowel prep and what these polyps look like. So here you can see if you have a family member and they had a colonoscopy, they had some polyps, the questions for you to ask is how many polyps did they have? How advanced was the polyp on pathology? What was the size of the polyp? Because your risk will vary dependent on that information of your family member. So a tiny polyp, here you can see it can grow with time to a larger polyp and can ultimately result in a colorectal cancer. Here you can see on the right side of the screen. And in the middle, this slide is a good example to show you the importance of good quality bowel prep. all polyps are not protruding. Some can be flat, like a carpet or a sticker. And those polyps are really hard to see if you have even tiny amount of bile or stool coating the colon wall here. And here you can barely see any polyp there, but after that area is cleaned up, you can see a flat precancerous polyp. So what age we should start colonoscopy in patients who have different polyposis syndromes? So here is a comprehensive list. We thought that in average risk individuals, we start at 45. Or if you have family history in first degree, we start at 40 or 5 years and repeat every 5 years. But it is important to know if you have any known gene mutation in the family or a known hereditary cancer syndrome, because you will not be waiting until age 40 or 45 to do colonoscopy. That will be too late for many of these individuals. So, for example, if you have FAP, you want to start colonoscopy at age 10 to 12 years. Many of these will go to have colon cancer by early to late 20s or 30s. So waiting till 45 is too late for these patients. And here in the list, you can see for different syndromes, most of these, we start colonoscopies very young in life. And there are certain conditions we even start scoping earlier at age 8 for some hematomatous polyposis syndromes. So a little bit few words about Lynch syndrome. So Lynch syndrome is the most common hereditary colorectal cancer syndrome, and it's named after Dr. Henry Lynch. Dr. Lynch was a visionary, and he proposed cancers being genetic rather than just environmental in 1980s, when we had very minimal information about genes or genetics. And he was a very interesting person. He actually was a gunner in Navy at some point. And my favorite is he was a professional boxer with a nickname of Hammering Hank. So about 1.2 million individuals in this country have Lynch syndrome, and 1 in 1 to 25 colorectal cancer is due to Lynch syndrome. And as I already mentioned, 90 to 95% of these affected individuals are not aware of this diagnosis. So we do strongly feel that, knowing your family history, knowing your risk factors, and being tested will change these numbers. And we do want to move towards that, to know that individuals have Lynch syndrome, offer them appropriate screening, and prevent a cancer or improve the outcome, and not do the other way, like doing the testing when you already have a cancer. So Lynch syndrome, is caused by 5 different genes. And when I look at a patient with Lynch, they all are different in the syndromes for me. It depends on which gene they have and what mutation and what their family history is. So here you can see that if you have MLH1 gene, colon cancer risk goes to about 40 to 60%. And compare that to general population, which has about lifetime risk of colon cancer of 4%. So here, these patients will start colonoscopies at age 20 to 25, and some other genes which are less penetrant, they start at age 30 to 35. And these patients have to repeat their colonoscopy every 1 to 2 years or every 1 to 3 years on MSH6 PMS2 genotype. So here again, I hope this slide emphasizes that waiting till age 45 for colon cancer screening will be too late for these individuals. So if you have Lynch, we want to know at younger age and offer the screening options at much younger age and much more often than we do for average risk population. And pathway to cancer formation is accelerated in Lynch syndrome. So generally we say that if you have a small colon polyp, it's going to take 10 years to turn into cancer. But that's not true for Lynch. All colon cancers in Lynch do not, they are not developing from a polyp. there is something called abnormal crypts. These are some cellular changes, and they can turn into a cancer without ever having a polyp. And that's really important, that even if we do colonoscopy, some of these patients may end up developing colon cancer. And that leads to the need for chemo prevention, which is taking some medications to lower the risk of cancer formation, and maybe vaccinations for lowering the colorectal cancer risk. So we have aspirin. There is plenty data that it can lower the risk of colorectal cancer by 50% in Lynch syndrome. And there is some emerging data about resistant starch intake, which can lower risk of upper GI tract cancers in Lynch syndrome as well. So what's the other reason? If you have a colon cancer, you do want to know if you have Lynch or not, because the type of surgery your surgeon will offer may change. Instead of offering a limited resection of the colon, they may do more extended resection of your colon if they see you have Lynch syndrome. And also, if you are a postmenopausal person and you have colon cancer because of Lynch, your surgeons may offer to do removal of your uterus and ovaries at the same time, which is part of risk reduction in Lynch. So having that information before you see the surgeon and the oncologist is extremely important. And here at UCSF, one of my projects is how we make sure that patients who are diagnosed with colorectal cancer by an endoscopist, they also have a process to initiate genetic testing early on. So by the time they go and see a surgeon or the oncologist, they have that information, because genetic testing takes time. It can take 2 to 4 weeks for the results to be available. So here, quickly, let's go to a case example. So 18-year-old woman, she has persistent blood mixed in her stools. And for months, she was thought to have hemorrhoidal bleeding. She has no family history of any colon cancer. And her colonoscopy shows these numerous, hundreds of thousands of colon polyps. And her gene testing shows she has familial adenomatous polyposis, which is FAP. And management of these individuals, as we talked, they have almost 100% risk of colon cancer. So these patients undergo removal of all of their colon to lower their risk even before they develop a colon cancer. And here is an example of colon specimen taken out in surgery. And here you can see these tiny dots are all colon polyps. So we do follow several of these patients here in our clinic as well. A few words about UCSF Lynch Syndrome Center. So I'm very fortunate to work at UCSF, being mentored by Dr. Terdiman. I have Amie Blanco here as well, who got me excited in this field. So we recently launched the UCSF Lynch Syndrome Center. And here we have added a hereditary cancer risk calculator. This is a link you can go to. And the link will show you, this is a screenshot, a calculator, which is based on REDCap we have built. So very simple calculator, takes just a few minutes, and it asks you your family history questions. And we have used NCCN, which is National Comprehensive Cancer Network guidelines. And in the back end, the algorithm will tell you, based on your information, if you meet testing criteria for Lynch syndrome, and also the most common breast cancer syndrome as well, so BRCA 1 and 2. So this can be a very helpful tool for you to utilize, and based on that information, it gives you directions if you want to be seen by a genetic counselor at UCSF. And if you live outside UCSF, we also provide you a link to find a genetic counselor in your area and seek help. So a few words about Lynch vaccine trial. So I'm fortunate at UCSF to be a site for this NCI, National Cancer Institute, sponsored Lynch vaccine trial. So what this vaccine includes is it's a vaccine with 3 tumor antigens. So there are certain antigens that are proteins that are made just on these tumors, and these tumor antigens are taken and attached to an adenovirus, which has been altered that it can't divide inside your body. And those antigens on that virus vector, they are injected in the form of the vaccine. And that leads to development of your immunity, your antibody, your immune system is activated. So when you develop a polyp or a cancer in the future, your immunity can take care of those polyps and cancer. So this concept is very novel and exciting. And this study will last for about 2 years, and we are very excited to see what we learn. And I truly hope the results are positive. Also, some other facilities we offer at the UCSF Comprehensive Lynch Clinic. Here, we are excited to have some options to do endometrial biopsy for patients. At the same time, they undergo colonoscopy. We have some specialized beds in endoscopy unit, and we are able to facilitate that. So in conclusion, I hope I was able to share that about 10% of colorectal cancer individuals can have a germline genetic mutation, and timely diagnosis of hereditary colorectal cancers can prevent cancers formation and improve outcomes for the patients and their family members as well. So it's really important to talk about your family history and your colon polyps with your family members and your providers as well. And with that, I will end my part of the slides, and I'll pass it on to Dr. Munster to share her slides. And I'll be happy to answer any questions in the Q&A. Thank you.
Thank you so much, Dr. Singh. Very informative, and it's always amazing how much progress we make over the months since I last heard you talk. It's like and with this, I also try to share a little bit of the excitements we see in patients with Lynch syndrome, and what is new in the treatment of patients with hereditary colon cancer. Now, many of you may know that I'm a medical oncologist. I see patients often when they have very advanced tumors and when the tumor has spread. So what I like to talk a little bit is like, and what is the mechanism of Lynch syndrome? What is mismatch repair, and why is this so exciting for us in terms of advances in treatment? If you remember on your high school DNA structure, the DNA is a long string of nucleotides that have two types. There's a G and C, and there's A and T. And they have, sorry, I'll switch this over. They have to go and be matched with the right pair in a sort of like a cartoon here, like yellow has to be matched with green, and red has to be matched with blue. Now, occasionally, as you know, nothing in life is ever perfect. The same holds true for the DNA. As the DNA opens and closes and forms new cells, there's always changes happening, and errors are made. If you have an intact DNA repair system, and you have a mutation here, a whole cascade of enzymes and other factors will come here, cut this area out, and repair this. If you have a DNA mismatch repair problem, like as Dr. Singh and Ms. Ertan just discussed, is like you may not be able to repair properly. And over a life, what happens is there's a lot of unstable chromosomes are accumulating, and you see an enrichment of mutated microsatellite, and that has created the term of microsatellite instability. Now, when patients have mismatch instability, that can actually cause a whole series of cancers. These include mainly colorectal cancer. You see the majority of these mismatch repair tumors are really colorectal cancer. And then in blue, endometrial cancer, gastroesophageal, and other cancer can happen with this mismatch repair. And they've historically been treated with chemotherapy. But then in 2014 and 2015, immunotherapy was introduced into the treatment, and immunotherapy does something differently. Immunotherapy does not provide a poison to your cells, but it stimulates your very own immune system to start and go recognize defects or mismatch or microsatellites accumulation. So what happened is the first immunotherapy was introduced to patients with mismatch repair. And then what we look here is we see when a patient has complete eradication of their metastatic disease. This first study was for patients who had colon cancer, endometrial cancer, other cancer that has spread and become metastatic. And you see a very large group of these individuals actually had complete eradication of their tumors with just immunotherapy, no chemotherapy. And many of them had some shrinkage of their tumor that was durable. A few patients had no response, and they were subsequently treated with chemotherapy. So this has then led to the question, could we use surgery plus chemotherapy versus immunotherapy? And what the patients who were now, again, had metastatic disease were then randomized to either receiving chemotherapy or pembrolizumab, which is an immune checkpoint inhibitor. And what you see here, despite the fact that patient had metastatic disease, their tumors have spread beyond the initial colon. Many of them had a really good response to immunotherapy. And what's really important, at almost 4 years, more than 60% of patients were still alive. This is overall survival. So patients with Lynch syndrome, even if their tumor has spread at 5 years, over 60% of these individuals were still alive, in contrast to 50% with chemotherapy. So what this tells us is chemotherapy is effective, but immunotherapy is probably more effective. But it is also true if someone doesn't respond to an immune checkpoint inhibitor or immunotherapy, they can be treated with chemotherapy and vice versa. So all of a sudden, these patients have multiple options with very durable overall survival. So this tells us a little bit who benefits. This is what we call the forest plot. And we look at in depending what the patient's circumstances are, we then look whether chemotherapy works better, which would be favoring chemo, or immunotherapy is better. And you can see here, it doesn't matter whether you're older or younger, whether you're male or female, whether you're from Asia, Western Europe, or the rest of the world, whether you had a newly diagnosed or a tumor that has recurred, pretty much everyone has more benefit from from immunotherapy. So where has this led us now is like now we have gone to trying to figure out what happens with prevention. Could we potentially prevent tumors from recurring? And what I'm showing here in a very complex slide is what was very interesting. So they followed these patients who either got immunotherapy or chemotherapy over the next 4 or 5 years. And what they found is that those who gotten immunotherapy had much fewer tumors that were significant. They had more skin cancer. So for some reason that we don't quite understand yet, patients who got immunotherapy had more skin cancer. The skin cancers were, on a good clinical exam, were easy to detect, easy to get taken care of. At the same time, they had much fewer tumors in the inside of their body. At the same point, the patients on chemotherapy had more tumors. So suggestive that maybe immunotherapy, when the tumor is spread, also will prevent future cancers. And then in the next step is the question is that for patients with rectal cancers, with rectal cancer is typically treated with surgery and chemotherapy. As you can imagine, because of the rectum fulfills a very, very important part of our daily bowel functions. this can be very devastating for many patients. But so what they looked at is, could we maybe get away for doing surgery? So this was published in the New England Journal as with this probably one of the very few papers that was published based on just 12 patients. So what these researchers did, they took patients with rectal cancer and they gave them immunotherapy. And what they found in the first 12 patients, everybody had a complete response. All of the 12 patients, their tumor was completely gone. They had no chemotherapy or surgery, they had no progression or recurrence. And this came at is not a lot of side effects. So hopefully what future studies will show and what we'll see is that maybe Lynch syndrome does not need chemotherapy, may not need surgery, but that's why clinical trials are really important. And I would like to really urge you to join centers with clinical trials. Dr. Singh has told you about the vaccine trial. And I think this is really important that patients with hereditary tumors or hereditary mutation with the risk of tumors join clinical trials to see whether we can actually intervene sooner and may not need chemotherapy or surgery. So with this, I actually would like to now go to our Q&A and please answer questions. But before we do this, I'd like to ask our panelists a few questions. Dr. Terdiman, after hearing us all speak, could you give us a few words, what is the most exciting thing you've seen over the last couple of years in your practice?
Well, I think the most exciting or important thing is our ability to recognize patients with these syndromes and to recognize them early. When I started many, many years ago, we did this solely based on people's family history. So it was essential that a practitioner sit with the patient, talk to them about their family history. A lot of the times the family history was unknown. The practitioners didn't have the time to ask. People didn't have much of a family, so there wasn't much opportunity to have a family history. And so then we evolved from that to doing augmenting the way that we detected families. And that started with tumor testing. So then we started to be able to look at people's tumors and see if there were clues in the tumor as to whether or not they have these syndromes, especially Lynch syndrome. And then once we figured that out, we started instituting universal testing of tumors to see if they had these molecular changes that would tip us off. And now we're evolving again. We still do those things, and those are still the conventional ways of finding families. But now we have these really rapidly, easily available multi-gene panel tests. And we still are in a kind of a situation now where often we decide whether or not to do those tests based on taking the family history, the very old-fashioned thing, looking at the tumor, looking at certain tumor markers. But I think we're getting ready now to evolve again, where certainly all cancer patients will have these panel tests. And probably we'll move beyond that to a point where people will just have the panel test before they have cancer. And the idea, again, is to try to identify people with these syndromes even before they have cancer, or to identify them immediately upon their diagnosis so that we can impact their therapies and also impact all of their family members. So that's the evolution, and it continues to evolve. I think that's what's most exciting about the field.
Thank you, Jonathan. Amie, you and I have been doing this for many, many years, and as a parent, if you know that you have a genetic mutation, and Dr. Singh just told you how early you need to screen, how and when does a mother or a dad with this syndrome approach their children? You're on mute.
Thank you. That's a very good question, Dr. Munster. I think my first response to that is every family is unique. Thank goodness, right? That's what makes the world interesting. Every family is unique, and there's no one right or wrong answer for how or when to talk to one's children about an inherited cancer syndrome. But what we do know is that talking with children in an age-appropriate manner earlier than most people think ends up with better outcomes for the family and for the kids overall, in that they start to integrate this knowledge into their daily life. It's not something that's really scary. It's just something about the family. And when they become of an age when we would want to start screening, that is really sort of our point where you might have genetic counselors like me be a little bit more aggressive talking with patients about disclosing the information to their children, because we really want to intervene to try to prevent cancer or find it as early as possible, and not wait until we need to think about things like surgery, chemotherapy, even immunotherapy. As wonderful as it is, there are still side effects. So each family is unique, but the younger you can start having these conversations, the better. And genetic counselors can help individuals, think about when the right time is to talk to families. I've had families where with multiple children, and each child was told at a different age because that's what was right for them.
Thank you, Amie. Sarah, I'll let you expand a little bit on this. It's like, if someone hears us talk and is not part of UCSF, how would they go about getting genetic testing done if they have family members with colon cancer?
Great question. So there's a lot of different ways now that people can get genetic testing. So if people are interested and they're in California, they can always meet with the UCSF Cancer Genetics Clinic. There's information online about how you can kind of self-refer or help your PCPs refer you to meet with one of us to talk about options. There's also the Genetic Counseling Organization, NSGC, has tools about how to find a genetic counselor near you. And there's different labs that also offer genetic testing options. Sometimes those are a little bit less customized to family history, but there's certainly a lot of different ways people can find their way to genetic testing.
And then does everyone in the family get cancer? Does everyone get the mutation? Can you speak a little bit more to this? I know you've addressed this in some of your talk, but I think maybe this deserves a little bit of an expansion.
Of course. So I always like to emphasize to people that an increased risk for cancer is certainly not 100% risk. And by knowing whether or not someone has that increased risk, we really can take steps to lower the risk. So certainly having a gene mutation doesn't mean that someone is going to get cancer for sure, but it's important that we know that information, that we're doing our best job of screening. And in those ways, hopefully, if there is a cancer, we're catching it early where it's not as big as an issue. So gene mutation does not equal a cancer diagnosis, but it's important to think about what those risks might mean moving forward.
And Amie, another question on the genetic testing. Can people get penalized for having a mutation? Is that going to interfere with your ability to have insurance or have life insurance? Can you speak a little bit to this?
Sure, I'd be happy to. That's a very good question as well. So in the state of California, we have very strong protections in place regarding kind of anti-discrimination laws based on a genetic test result for both health insurance, but also even for life insurance, which is slightly unique. Life insurance is a little bit unique to California. Nationally, there is also fairly good protections in place to prevent a genetic mutation or a genetic syndrome from being considered a pre-existing condition or something that you could be penalized for within your health insurance. Now, these national laws say that if you have a group health plan, for example, you work for Google and you get your health insurance through Google. This is a large health plan, and your health insurance can be no different than anyone else's. Your gene mutation can't change your health insurance. It can't change your employment. They can't make hiring decisions or firing decisions or any type of decision based on that genetic test result. And that is written into law. I think the one area where we still worry a little bit is young people who have small insurance programs or a self-funded insurance program. The protections are not as strong in that situation. So talking with the genetic counselor about what that might mean for you, I think is a good idea. But by and large, we have not been seeing cases of discrimination based on the result of an inherited cancer test, both in California and across the country as a result of these laws.
Thank you. And before we get into a little bit more in details, there was a question, Dr. Singh, about the resistant starch. I think that was everyone is excited to hear about the resistant starch. Can you talk a little bit more about that?
Absolutely. So yeah, so what resistant starch, they are a kind of carb, but they are not the bad carb. So what those carbs are, they are resistant, meaning they're really hard to digest. So what happens is those carbs, they enter your colon and they act as a food for healthy bacteria. And the proposed pathway is they act like a prebiotic, and you end up creating a healthy microbiome, which reduces, your risk of stomach cancer and have also been seen in some other cancers. And I will share the link to a pamphlet that one of the families, and they're very open and public about it, who lost their daughter at age, like a very young age, I believe less than 20, because of delay in diagnosis of Lynch syndrome. They are a strong advocacy fund, and they have a foundation. I'll add the link here. I had an honor of meeting them a couple of days ago, and they shared this pamphlet with me, which I'm happy to share with my patients. And I appreciate their help in increasing awareness. So generally, the food that are high in resistant starch are like green bananas, oats, lentils, legumes, plantains. So finding ways to add them to your diet, for example, adding a green banana to your smoothie, adding some oats, and not cooking them a lot. It's in a little bit pre-cooked stage can be helpful in maintaining a healthy microbiome. So it's something we would like to see growing evidence for, but it seems pretty harmless intervention based on the limited data we have. So why not try it? And I think I'll add the link here for everybody.
And by green bananas, you mean not a special brand, but those are not ripe?
Yes, that's just not ripe. Yes, I'm not a big fan of those, to be honest. But you can try green banana flowers is the other option. I have seen people being creative in ways to include them, but lentils, legumes, oats.
There are many sources you can look up and see what's palatable to you and your diet, many forms. Generally, if you're hoping that it's going to help you, you need to take about 30 grams a day. So you have to see how that translates to whatever starch you're eating. It will differ. In the largest study that directly looked at this in Lynch syndrome, it did not help actually reduce the risk of colon cancers. So that was sort of disappointing. But it did seem to maybe help reduce the risk of non-colon cancers in Lynch syndrome. And then there's a lot of other potential health benefits. We use these sorts of things in patients with inflammatory conditions, things like inflammatory bowel disease. It might be beneficial, all sorts of other things. So it's definitely health promoting generally. In terms of cancer reduction, a little controversial, but not harmful.
Exactly. And as Jonathan said, really important you try small amount at a time, because if it's causing gas and bloating, not really a sustainable option for anybody.
And Dr. Terdiman, doing a colonoscopy every year seems pretty daunting. and both of you, Dr. Singh and Dr. Terdiman, what are the tricks to make a colonoscopy a little bit more palatable? And there must be some things that work better than others. What is things you shouldn't do before a colonoscopy? Can we hear the insights of the experts?
Okay. There's no easy answer to that. So first off, you want to do the colonoscopy as often as you need to do it, but not more often than you need it. So for example, so this is something, it's hard to go through each of the syndromes and each of the genes, but you really want to understand your personal risk for colon cancer. There are situations where the right answer is a colonoscopy every year, occasionally even more than every year. But sometimes, even if you're at elevated risk, you can get a lot of the benefit, just as much benefit if you do the colonoscopy every 2 or 3 or even less often years. So you really want to know what's the appropriate interval. For example, in that big array of Lynch genes, the actual risk of colon cancer isn't really the same with all of the different mutations. And so for some of the genes, you don't actually have to have colonoscopy every year. So it's important to sort that out. The other thing is Dr. Singh and I and others are working hard on ways of detecting precancers and early cancers without colonoscopy. So first, we want to prevent them, right? So we're working on things like the vaccine, and maybe eventually that's going to mitigate the need to do a colonoscopy as frequently or at all. We didn't really talk a lot about chemo prevention. Again, at the moment, it's not at a place where it changes our recommendations about colonoscopy, but we're working on all of that. And then you heard about non-colonoscopy screening methods. So still, for these cancer syndromes that we talked about today, the risk is so high that we don't think that any of the non-colonoscopy methods are as good. And the question is whether or not they supplement colonoscopy. But I think over time we are going to develop things, for example, the blood testing that Dr. Singh referred to. In terms of what to do when you're having your colonoscopy, my biggest recommendations are to, in the week before the test, take a low fiber diet. It actually is a little easier to be cleaned if you do not eat lots of fruits and vegetables in that week before you have to do the exam, and you'll end up with an easier prep and a better prep. There are increasingly palatable preps. There are these low volume preps. You don't really need to drink the big gallon anymore. So you want to talk to the gastroenterologist or the nurse about like, what are the prep options? And some are definitely, they're not for everyone. You have to know the details of people's medical condition, but there are definitely some that are much easier and then others. And then you want to go to, a really good endoscopy center, obviously with nice nurses, and do appropriate sedation, have a good colonoscopist and all of those things, which we have, of course, at UCSF. So, but yeah, it's not a super pleasant thing. And at the moment, despite all of that, there's certain things you just have to get through it.
Dr. Singh, anything to add?
No, I completely, agree. I mean, there are certain dietary changes you can make based on your preferences. And I think someone in the chat shared the ginger ale. Yes, if you like those, adding some of those clear liquid diets like Gatorade, and those can be a good option. But one of the advancements in colon prep has been that we have seen data that you don't really have to be on a clear liquid diet the day before your colonoscopy. What we have found in our studies that a low fiber diet, even just the day before procedure, it may just work out really well for cleaning your colon. So if you're not a person who has constipation, who has high BMI, who has history of past poor prep, so you may be a candidate for having a low fiber diet even the day before. And that some people feel that you're not starving, so you may just do better tolerating the prep and not having to vomit and all those things, and that may add and facilitate your quality of prep. Other things like, drink with a straw, chill just chill it while we use it. Use some non-red gummy bears, and many of these are like options to consider. So, but the biggest one is, yes, not having a high fiber diet. And not the time to go for movies and have popcorn, you know, in the week before your colonoscopy. That's something I read, seeing seeds is absolutely impossible for me to clean the colon if there are seeds. So please, no popcorns or seeds the week before your colonoscopy. As we shared, those tiny flat carpet-like polyps, those are the ones they can be easily missed if the prep is not pristine. So definitely our job depends a lot on how good the prep is. So some of these tips and tricks to try. And I'll just add that if you're a person who has constipation, has high body mass index, bring that up to your endoscopist and possibly have some backup options, you know, to help and facilitate on top of the routine amount of bowel prep. So in certain situations, I give double dose. In certain situations, I anticipate, and if someone has a bad constipation, I may give them some Dulcolax tablets to be taken on top of the routine amount of the laxative that we give to everyone. So have that discussion. That's better than, you know, having a poor prep colonoscopy and being asked to repeat that. So I hope that helps. Yeah.
That is very helpful. So expanding this a little bit, so there's a lot of in the world of cancer prevention and early detection, there's a lot of talk about whole body MRI and other imaging studies. Does this work to prevent and detect colon cancer?
Well, if you want the short answer, no. Jonathan can give the long answer.
So that's the answer. Unfortunately, no. So,
so can you speak a little bit, why does a CT scan or an MRI not detect polyps or colon cancer?
yeah, I mean, there are ways of formatting those exams. You can have an exam, an MRI or a CT that will look for, because we of course don't want to find advanced cancer. So if you're talking about detecting an advanced colon cancer, CT scan is extremely good for that, right? Once you have a large mass or you have metastases or lymph nodes, but that's a disaster. We want to, you know, we want people not to be diagnosed at that stage of disease. So a standard scan can't really peer inside of the bowel very well. It can't see precancerous lesions or early cancers, in part because when you do these scans, the bowel is often collapsed. You haven't done a prep to clean the bowel out, so it's full of poop. So the scans just aren't able, the way they're formatted now. Now, you can do a scan for prevention, which basically will require that you do a prep, just as if you were going to have a colonoscopy, and actually have some air insufflated into the colon so that it will distend. And then actually the colon, a CT scan or an MRI can find polyps. The problem is that if you go through that, you still had to do the prep. So it's not really saving you the hardest part of the exam. And then if a polyp is found, you would still have to then come back and do the colonoscopy. The other problem is that in some of the cancer syndromes, like the Lynch syndrome, often the polyps grow in a very subtle way. Dr. Singh referred to the fact that they grow as like little stickers or patches, or they're very flat. And those tend to be the precancerous polyps in Lynch syndrome, which is, of course, the most common of these hereditary syndromes. And the scans really are not sensitive enough to find those lesions. Even when we do colonoscopy, direct colonoscopy, it takes really careful inspection of the surface lining. And we do different things optically now to try to see those lesions better than we did in the old days. The scans just can't do it, not yet.
Thank you for that. Going back a little bit to more like a practical question, Amie, if someone had colon cancer at 50 and now they have a genetic mutation and the person only had colon cancer at 50, can people wait with screening until they are like about the same age, or like, do they really need to start at 25? How reliable is family history and the onset of age for a relative?
That's a really good question, because we find that there are patients in their 70s being diagnosed with Lynch syndrome for the first time. There's no age that is sort of off the hook for a diagnosis of colorectal cancer being related to Lynch syndrome. But the flip side of that is that there's also no strong relationship between the age at which your relatives were diagnosed with colorectal cancer and Lynch syndrome. The risks increase based on age. And so when you get to a certain age, that threshold where the benefit of screening outweighs any risks of screening, we want to start screening. And so in Lynch syndrome, that tends to be ages 20 to 25 or 30 to 35, depending on the gene that is impacted. But just because, for example, my parent might have been 50 with colon cancer, if I have Lynch syndrome, I can't wait till 40 or 45. I really do need to start at the appropriate age, 20 to 25.
Okay, thank you.
Yes, I'll definitely emphasize that, Dr. Munster, this question is brought up by patients often. And in my clinical experience of taking care of hundreds of patients, how often we see the only family history is a colon cancer in 70s. And my personal patient, which I have just a few weeks ago, has colon cancer in her early 30s. So we do see some data that the stronger the family history, the gene is likely more penetrant and is likely going to increase the risk in your patient. So definitely family history helps. But even though it's a common question, as of now, we do not understand why that in the same family with the same mutation, some people never had a cancer or some had such delayed, and would that same thing apply to the person I am looking at? We do not understand that. And I see the opposite happening all the time. So as of now, we do stick to the guidelines, but I hope we can do more, patient-specific recommendations in the future. Not there yet.
Okay, Sarah, if a person has Lynch syndrome, what other cancers are we screening for, and what are we looking for?
Good question. So while colorectal cancer might be the highest risk factor in Lynch syndrome, there are certainly other cancers that we think about. For people who have a uterus or ovaries, I think about endometrial cancer being a pretty high risk. And endometrial cancer is one where we're still kind of figuring out the best way to screen and manage endometrial and ovarian cancers. So we can do things like an endometrial biopsy. So the chair Dr. Singh was showing, we can sometimes do that at the same time as a colonoscopy. But currently for people with Lynch syndrome who again have a uterus or ovaries, we also think about potential for preventative surgeries. So having a hysterectomy or an oophorectomy where we take those out is an option for reducing those cancer risks. And that's something that's quite personal, whether or not someone might choose to do that. We wouldn't do it necessarily at 20. Often we wait until people are a little bit older. So some room for personalization with that. There's also other risks we can see, like things like bladder cancer or different skin manifestations. So we might do a urinalysis test to check for bladder cancer risk. We might recommend meeting with a dermatologist to get kind of a top to bottom skin exam to make sure there's nothing going on there. But it can really vary somewhat based on those genes that are or aren't working. And it also depends on your family history sometimes, a combination of both family history and your genetic test result. So those are in general some recommendations we have, but important to make sure you're meeting with your doctors for considering your personal and family history risks as well. And anything that you would add to that, Amie?
I think the only thing I would add is that we do like to do upper endoscopy when we do colonoscopy. So look at the stomach and the first part of the small bowel when our Lynch syndrome patients are having colonoscopy, because there is an increased risk with some of the genes for gastric cancer or even a small bowel cancer. And it doesn't really add much time or effort to the procedure. It's one bowel prep. It all happens the same day. And so it is something that we like to do here to make sure that we're addressing the gastric and small bowel cancer risks.
So to add to this a little bit, is like I think part of the reason why we created the the Lynch Center, the Hereditary Cancer Program is, I think it can be pretty daunting for a patient to figure out what all the screening is that is one supposed to do. And then what we find is another really challenging matter is actually, well, who is ordering all of this? And many of our patients find that it's often quite challenging, and the doctors may also not always be quite clear on what the changes are. Like Sarah talked a little bit about doing a urine test. And I think we have gone over the years back and forth. Do we do routine urine testing? Do we not do urine testing? We don't have clarity around this. So I think it's really important to recognize that some of these things are really well done at the center with the very specific expertise. And you may need to have a Lynch syndrome expert, and you may have to have a BRCA expert. And again, because it's the recommendations are constantly updated and changed. So I think it's really important to check in with us once in a while.
Absolutely.
Yeah.
Yeah, yeah.
And these decisions have to be personalized. There's certain areas where, like for colon cancer and colonoscopy, it's unequivocal that the colonoscopy is beneficial, and we have a fairly robust data set that shows us the magnitude of benefit. Probably if you're doing colonoscopy according to the guidelines, you'll reduce your risk of dying of colon cancer by 80 to 90%. With the other prevention tests, it's much less certain. And that has to do with some uncertainty about the risks of the cancer and the ability of the test to mitigate that risk. And so it doesn't mean necessarily that it's wrong to do the other tests, but it becomes a more personalized decision to really sit down, hear what are the data, how much time do you want to spend testing, what do you feel, people have sort of a notion about that they want to be more proactive, or they'd rather wait until there's really, really strong data to do certain tests. So all of those things really require expert guidance. And then there's new data comes in all of the time. So it is important to get an expert, consultation, and to have a plan mapped out that is updated based on new information.
I agree, Jonathan. And so as we were mentioning, so here at UCSF, we have Lynch clinics. So I'm a gastroenterologist, but I put on a hat of a Lynch provider. And when I see these patients, I'm not just talking about their colon cancer or gastric cancer risk. We talk about their every single organ that's at the risk, even talking about their family testing. How do we help the family members as well? And I'm fortunate to have the expertise of my urologist, dermatologist, and other specialists in advanced endoscopy as well, who have a special interest in managing these Lynch patients. And we just talk about every single organ and discuss, as Jonathan mentioned, like, this is the data, this is your risk, this is your individualized risk based on your family history, based on your genotype. And this is the data that this specific intervention, for example, a urine analysis, whether it works or not, and would you like to proceed? It can result in false positives. And then if you share all of that information, many patients are able to opt out, or, some, if they have a strong family history, they have MSH2 genotype, they are men who have a little bit higher risk, they may opt in as well. So having these discussions are very helpful for patients, other than just giving them a checklist that you need all of these, and that can be very confusing for them to just go to their primary care physician. So for us in Lynch Clinic, we order all of these things as needed. We make the referrals. If they're due for prostate PSA exam, we place the order and follow that along. And I see these patients once a year, and they know to reach out to me if they develop any symptoms in between as well, like if they have unexplained iron deficiency, anemia, things like that, which I want to know. Those are really important to me. So we definitely are able to provide this comprehensive care. And I feel that that's really important for these patients, you know, who go through a lot, And I love that on the same philosophy for patient-centered care, I'm very proud of this joint endometrial biopsy that we are able to offer during colonoscopy. So patients come for colonoscopy while they are sedated. I'm very fortunate that, you know, one of our nurse practitioners from Mission Bay, she'll come all the way to Mount Zion. And by the time I finish their colonoscopy, the nurse practitioner is in the room, ready to do the endometrial biopsy while patient is still sedated. And I have timed this. It just adds only a couple minutes to the procedure. And of course, for the patients to be able to do this in a combined fashion is pretty amazing, the feedback we receive. So yeah, I'm looking forward to expanding these programs and see how we do next year.
Thank you. Both of you, Jonathan and Appy, what are symptoms of colon cancer? What are people supposed to look for?
So the classic symptom is no symptom. So that's why you need to do the test even before there's any symptoms, right? You have to do the prevention test because by the time symptoms develop, often a person has a more advanced cancer that is going to require not just surgery, but chemotherapy or radiation or other things to be treated. So symptoms are not a great way of figuring out, of mitigating your risk following symptoms. And that being said, the classic symptom would be rectal bleeding for a low tumor, developing a new blood loss anemia or iron deficiency anemia on labs for a tumor that's in the more proximal part of the colon. And then, yes, any sort of unexplained abdominal pain, a change in bowel habit can be signs of colon cancer. Often things that people get very anxious about, like a change in their stool caliber, is extremely rare. That's a symptom of colon cancer. I would say bleeding is a much more important symptom. But yeah, any symptom that comes up, if you're anxious, you should be interacting with whoever your doctor is, with Dr. Singh or with me. Have a low threshold to ask. Part of whether or not you need to get tested again will depend a little, like when were you last tested? If you were tested a month ago, I think you're going to probably be okay for most symptoms and you don't need immediate follow-up. If your last test was 10 years ago, that's of course a whole different thing. We would say you need to be tested even if you don't have symptoms. So those are the classic symptoms, but you want to not let those symptoms happen. You want to be proactive and not wait to do prevention testing until you have symptoms.
And on that note, someone is asking how much bleeding and for how long, and like what does bleeding mean?
So if again, it depends. A little bit has to do with have you been tested before or not? Any bleeding should be investigated, no matter what your age. Okay, we actually, apart from the hereditary syndromes, we're seeing a lot of early onset colon cancer, especially rectal cancer in very young people. We don't really know what's going on, whether or not it will turn out to be genetic. So far, there hasn't been a genetic cause found for this uptick in what seems to be sporadic early onset colon cancer. But if there's bleeding in a young person, even if it happens once or twice, then that you should see a doctor about that and probably be investigated. Obviously, if the bleeding is larger volume, more persistent, that makes it even more worrisome. But all bleeding needs to be checked. And again, if you were recently checked and the doctor said, oh, you also have hemorrhoids or you have another source of bleeding, and then that continues or it just starts up again, then you may not need to be checked. It's not like every time you see blood, but if it's the first time it's ever happened and you haven't had a recent check, you must be checked, and really at any age.
And I think, thank you for the no symptom is an important symptom, because that's what I see as a medical oncologist. I see patients with very advanced cancer have no symptoms at all. if you had increased risk for colon cancer, I think you should have colonoscopies. That's probably the best way to get detected for that. Sarah, we're coming to the end of our session. Anything you feel strongly about, any advice that you give people, how to go about genetic testing, when to do it, who should do it?
Of course. I say if you have questions about genetic testing or your risk, I think anyone should meet with a genetic counselor. Our whole job is to help you better understand your risk. So I sometimes see patients who have no personal and family history of cancer, and I sometimes see patients who have very advanced cancer. There's not necessarily a right time. Certainly with those stronger family histories of cancer, we're more concerned, but I think anyone can meet with a genetic counselor to think about their options and their risks. Like I said, you can find more information about the UCSF clinic online. Most of our appointments are virtual, so you can be kind of anywhere in California when you meet with us. You don't necessarily have to drive into one of our clinics, unlike when you're getting a scope procedure. So I know that my philosophy is kind of anyone can consider genetic testing, especially as it's becoming more available and we're learning more about how common some of these genetic conditions really are.
Can I ask the counselors a question? So what is your feeling in colon cancer specifically? What is your feeling about universal germline testing, panel testing versus selected patient panel testing? What do you say today?
So the data really supports a multi-gene panel for every patient diagnosed with colorectal cancer. As we test more people over time, we are finding inherited cancer syndromes that are not your typical Lynch syndrome or other inherited condition that we classically think of as being associated with colorectal cancer. And so if you limit genetic testing to the most common inherited cancer condition, meaning Lynch syndrome, we're going to miss a significant proportion of positive genetic tests where we do have guidelines for intervention and risk reduction. So I feel very, very strongly that the data supports universal multi-gene panel testing for every single patient diagnosed with colorectal cancer. I strongly advocate for it. We also know over the years that all of the things that we've tried to do historically, like screen tumors after somebody's been diagnosed with cancer, we don't always identify Lynch syndrome with that screening test. It's just a screen. It's not a diagnostic test. And the best way to actually close that gap is with a multi-gene panel for everybody with the diagnosis of colon cancer.
And I like to add to this is like, and I think in breast cancer, we have now multi-gene testing for anyone who's diagnosed with breast cancer, similar to ovarian cancer, pancreatic cancer. I think colon cancer gene testing has such enormous impacts on the patient as well as their family members. So I think we would be remiss not to recommend that.
I agree.
So just, I agree just to point out where that recommendation is ahead of the guidelines still. So, where it's in process, maybe the next iteration of like the NCCN guidelines will support that. Is there been a lot of pushback in terms of testing coverage, cost coverage, and that sort of thing?
No, there actually has not. Medicare in particular will cover genetic testing for any patient with a solid tumor at this point. And a lot of the private plans take their guidance from Medicare. So it's getting easier, not harder, for people with the diagnosis of cancer to obtain genetic testing. And we've got creative ways to help people not get astronomical bills when you do have cancer and are looking to have genetic testing. So just reach out to us. Be happy to help.
And then generally, Amie, correct me if I'm wrong, like limited gene panels and expanded gene panels probably cost the same.
Correct. Same cost. Whether you look at 5 genes or you look at 50 genes or 100 genes, it's the same cost.
I agree. And, in my practice, I I'm able to offer genetic counseling and even order multi-gene panel testing. And then what I have learned is the cost for multi-gene panel test, even without insurance, is less than $300, like between $200 to $250, even just out of pocket. So definitely has become very affordable for many of our patients.
Dr.
I
Singh?
want to point out that it doesn't stop. We still also have to test the tumors for other reasons. So
Yeah.
Yeah.
For immunotherapy. Yeah.
But I can share a little bit what's happening on the treatment side in patients with metastatic disease. Everyone has multi-gene testing, a lot of multiple panels, repeated testing. Often we see some of the gene mutations on the tumor testing. It still means like we probably still should do germline testing because they're often not prevalent there. So I think Jonathan, before we end our practice, hopefully we'll have global gene testing for everybody. Like that'll be my wish, and it would make a huge impact on the way we prevent and do early detection.
Yeah, I agree. I would say one of the things, it's not hard to implement universal testing with new diagnoses because, of course, those people are right in front of you. You're ordering all sorts of things for them. It's an easy flow and it makes sense. We, of course, also have a lot of, patients in survivorship that we don't interface with all the time, and capturing those people and going back is a lot more daunting to, track them all down, so to speak. So
that's a very good point. We do have a close relationship with our survivorship clinic here at UCSF, and we've been working with those nurse practitioners to implement a systematic approach to make sure that we're catching all the patients who were diagnosed 5, 10, 15 years ago, which, especially in Lynch syndrome, that is happening more and more and more, that people will be living a very long time.
Jonathan, any closing words from you?
No, I think that's really exciting. I do think Amie is kind of saying it should be the established practice now. It's certainly like right on the edge of being the new frontier / established practice. But I think it's really, I think it's still obviously important to individualize care, speak to everyone, take their family histories and all of that. But if we're really going to, mitigate the risk, ideally, we have to test everybody. And then we keep working on better ways to prevent cancer beyond just, in the case of colon cancer, colonoscopy.
Happy?
No, I just want to say thank you for organizing this, and thank you for including us. And, it has been amazing to see how far we have come for Lynch syndrome detection and management. And so I remain, very excited about the possibilities of the vaccine and even stool-based testing in the future. And many, states actually have launched population-based testing for many of these conditions, Lynch and BRCA. So I always say, why do we need for someone to have the cancer and then test them? It should be test them before they get the cancer. So I hope we get there someday soon. And I do appreciate you organizing these and increasing awareness. So thank you for that.
Thank you.
Thank you.
Amie?
Well, I would just say that I'm grateful for the work that you do every day, Dr. Munster. I know that it's actually extremely challenging. And you asked about kind of our recollections of one of the major advancements that really stuck out to us. And I will absolutely never forget the first time that I saw one of my Lynch syndrome patients who was 5 years post stage 4 colorectal cancer, who was now disease-free because of this immunotherapy. So being able to have relationships with these patients that mean so much to us for longer term and help their family members more and really be able to dive into that prevention is because of people like you. So thank you for the work that you do, but also for organizing for tonight.
Thank you all, and it's been, I think, an amazing panels. And I have to say, I always learn something new, and it's really amazing to see you all. This webinar will be posted on our BRCA website. Thank you all attendees for participating, and I hope this was helpful. I wish you a good evening, and again, thank you everybody for being here.
Good night.
Good night.